Hello, everyone, and welcome to the March UNSHAME Kentucky webinar. My name is Michelle Juma, Project Management Specialist at Shatterproof, and I will be introducing you all to today's topic, Why Our Words Matter, the connection between language, stigma, and overdose. To get us started, I'll go over some general housekeeping. The event is being recorded and will be available on the UNSHAME Kentucky website under the Events tab, along with a copy of the presentation. All attendees will be muted throughout the event, and please use the Q&A panel at the bottom of your screen to ask questions. The chat is also available for general commentary, but will not be moderated as closely. Also, feel free to introduce yourself and where you're joining us from. Very excited to see who's with us today. For best audio quality, consider listening to the webinar via phone line by using the dial-in number, or you can switch from computer audio to phone audio by selecting the upward arrow near the mute icon or the microphone icon on your screen. Quickly going over the agenda, we are going to start with an introduction to the UNSHAME Kentucky campaign, then go into our Why Our Words Matter presentation, a question and answer portion, and then close out. The UNSHAME Kentucky campaign is brought to you by the Kentucky Opioid Response Effort in partnership with Shatterproof. And I'd like to bring special attention to the Kentucky Office of Vocational Rehabilitation, who are providing American Sign Language interpreting services for this event and all future UNSHAME Kentucky campaigns. We're looking for ways to improve this webinar series, so a post-event survey will pop up on your screen when you close out of the event. I'll also drop it in the chat now in case you'd like to get started early. And with that, I'd like to introduce Courtney McKeon, Director of National Stigma Initiative at Shatterproof, to provide an overview of this exciting new movement.
Thank you, Michelle. For my role in today's webinar, I will kick us off with an overview of the campaign, but more importantly, I will also invite you all to join this movement to end the stigma of addiction across the Commonwealth of Kentucky. Next slide, please, Michelle. So the UNSHAME Kentucky campaign is a 12-month evidence-based behavior change intervention. It's aimed to reduce the addiction-related stigma held by Kentuckians. We are so generously funded by CORE through a grant from SAMHSA. CORE seeks to expand and sustain a comprehensive, equitable, recovery-oriented system of care, and they do this through the implementation of over 200 evidence-based programs across the state of Kentucky, with the goal of ending the opioid epidemic. The campaign will be delivered by Shatterproof, which is a national nonprofit working to end the addiction crisis in the United States. And one of Shatterproof's cornerstone programs is their evidence-based stigma reduction initiative. Next slide. Perfect. So the high-level goals of the UNSHAME Kentucky campaign is to improve knowledge, attitudes, and behaviors of the general public to reduce the stigma that they might hold for people who have a substance use or opioid use disorder. So this intervention has three main objectives: increase knowledge, and one of our primary messages is that recovery is not only possible, but probable; improve attitudes; and develop Kentuckians' understanding of the disease so that they can better support their loved ones who might have an opioid use disorder. Next slide, please, Michelle. So next, I will just dive in a little bit to the evidence-based approach, and I will also show you all how you can get involved with the campaign. So the primary content of the campaign is what we call our evidence-based stories of recovery. We know from the research that using a contact-based strategy, which means showing someone who has a stigmatized condition, showing ways to connect them with someone who holds a stigmatizing view, we know that that can really minimize the distance and make connections and make the story resonate more. So we focus on these evidence-based stories of recovery, and then we use 3 priority channels to really scale that message across the state. So we use community-based organizations, which is using them as trusted messengers within their communities to really share the resources that we're putting out, the testimonials. And then we use digital influencers and a targeted paid media strategy, as well as traditional social media web channels. Next slide, please, Michelle. So now to the good stuff. So our primary content, like I said, are these real life testimonials. And in Kentucky, and specifically, we're seeking to highlight the experiences of people in recovery, friends and family of people in recovery, or people who work in the substance use field. Michelle will be sharing out these slides at the end of the webinar, and you will see that there is a place where if you or someone you know is interested in sharing your story as part of the campaign, it's a really easy process to get connected with our program coordinator and start that process. Michelle, I'd love to share Jenny's story with those who are not familiar with the campaign or may not have seen our website or social platform yet.
Absolutely.
My name is Jenny, and I am 38 years old. I'm a person in long-term recovery for now a little over 14 years. I'm from Louisville, Kentucky, and found a thriving fellowship of people that are also recovering here in Louisville. It was so important for me to find a camaraderie, a community. These women kind of came into my life at the perfect time and almost mothered me into just bettering myself. Yeah, it was almost like I could breathe. I could finally let go and get this monkey off my back and take a step in the right direction. Feeling a part of, feeling connected, having accountability, and not feeling like I was doing anything alone. And that's, what life is about, is these amazing relationships that we build and that we attract. We can make a beautiful life for ourselves as long as we're willing to put the work in.
Thank you, Michelle. Next slide, please. Perfect. So as part of our formative research phase, which was about 3 months prior to the March 1st launch of UNSHAME Kentucky, we really started engaging with community-based organizations across the Commonwealth to understand the needs of the communities so that we could better tailor our campaign strategy to meet those needs and understand where the stigma, where were the stigma, what was the stigma, things like that. So we will continue to engage community-based organizations as part of our strategy throughout the 12-month campaign. But another component is our Community Impact Committee. Currently, we have our nomination form is open, and you will see that link at the bottom here. So please, you can self-nominate yourself, or you can nominate someone else that you think might be good for the committee. And the committee is a board of local community leaders, and they will represent the voices of the various Kentucky communities across the Commonwealth to really inform the campaign continuously, so that we are continuing to improve our strategy and keep doing the things that are working and pivot when things aren't working. So that feedback from that group is going to be a critical component to the campaign, and we need everyone to share out this opportunity so that we can get the right people on in those seats to inform the campaign strategy. Next slide, Michelle. And then last, but certainly not least, leveraging our social media to increase awareness is a pillar of the campaign framework that I shared with you earlier. So you can follow us on Facebook, Twitter, or Instagram. We have a wonderful, digital social media group that is really pushing out content every day, daily. They are either pushing out those stories that we talked about earlier. They are pushing out messages to increase knowledge. They are also sharing pictures that have been shared with us by community-based organizations. So that is a way that you can engage with us, is on our social media pages as well. And with that, I will pass it back over to Michelle so that we can get to our speaker of the hour.
Thank you so much, Courtney. So without further ado, I'll introduce our speaker for today's event, Why Our Words Matter, the connection between language, stigma, and overdose. Ed Johnson attained a bachelor's degree from Auburn University and a master's degree in clinical counseling from the Citadel. He has worked at the Southeast Addiction Technology Transfer Center, located at the National Center for Primary Care at Morehouse's School of Medicine in Atlanta since 2010, and is currently the Associate Director for Training and Technical Assistance. He has worked in the field of addiction treatment and recovery for over 30 years, providing direct services to the individuals with substance use disorders and co-occurring disorders. He has been providing trainings in addiction treatment, prevention, and recovery for over 25 years. And for the past 37 years, Ed has been a person in long-term recovery. He is currently credentialed and licensed as a licensed professional counselor, licensed addiction counselor supervisor, master addiction counselor, a certified clinical supervisor, and certified peer support specialist. Thank you so much for joining us today, Ed. I'll stop sharing my screen so you can introduce yourself or start off with our group.
All right. Okay. So it is wonderful seeing so many names of people I recognize. That is really, really cool. That's one of the sad things about this whole COVID mess. It's like not being able to actually see people when I'm doing trainings. It's sort of like I have to visualize that people are there. So as Michelle mentioned, my name is Ed Johnson, and probably of all that stuff that bio stuff that she shared, the most important thing to me, at least, is that I'm a person in long-term recovery, which means that, again, in coming up on 38 years, I haven't used any alcohol, illicit or non-prescribed medication. So very much today, my life is about recovery. Okay, I don't know how many of y'all have ever seen the musical Wicked or heard the soundtrack from the musical Wicked, but the first song that the wizard sings, he makes the statement that everyone deserves the chance to fly. And for me, recovery has given me the gift of flight. All of that other stuff that was read prior to me being a person in long-term recovery, and even after that, would not have been able to happen if it had not been for recovery. And I'm one of those people that I firmly believe that recovery is a gift anyone can have. It's not a matter of how you get them into treatment so much as it is a matter of how do you support their recovery within their own community. And that's a key component of what the whole idea of recovery-oriented systems of care are all about. So what we're going to be talking about today is the connection between language and stigma and overdose, okay? Now, one of the things, I work at the Southeast ATTC and Addiction Technology Transfer Center, and we're one of 10 regional centers that SAMHSA funds to do recovery and treatment trainings, and a big part of what we do is helping folks implement evidence-based practices, treatment providers and recovery organizations. And one of the things that is indeed evidence-based is that our language does matter. I mean, there has been quite a bit of research about the impact that the words we use has on the general public, but more importantly, has on the people who have substance use disorders. And there are all the states that we work with. And so learning objectives, because you always got to have learning objectives if you're doing a presentation. We're going to talk about 3 ways that stigma correlates to overdose. We're going to talk about some common phrases that contribute to stigma and the people who are in the field of addiction treatment and recovery use all the time and we don't think about. And we're also going to talk about something that is, again, we don't think about, but has to do with the fact that we've got a chronic medical condition that we're treating in the manner of an acute condition. How it would look if we treated a chronic medical condition, as in substance use disorders, like other chronic medical conditions. What would that look like? Okay. So hopefully today we're going to engage in a little expanding of your mind. I'll own the fact that being a child of the 70s, as soon as I saw something tie-dyed, I just had to have it. Of course, I wouldn't have been caught dead in anything tie-dyed back in the 70s, still wouldn't. I'm amazed at some of the folks that are my age that wear tie-dyed. It's like, stop it, just quit, let it go. One of the things, unfortunately, some of the stuff we're going to be talking about is probably going to cause some of your circuits to fry in between your ears, because we're going to be talking about looking at things in a different way than we have in the past. So one of the things that I'm going to ask before we get started is that you do your best to try and be open-minded and be willing to challenge yourself and some of your current beliefs. Because this discussion, and it's one of these deals, that this is the start of a discussion. This is not, you know, after you've listened to me for 30 minutes, you'll never use stigmatizing language again. That ain't gonna happen. I've been doing trainings like this for a little over 10 years. So for me, I don't use those terms, but again, I've been doing it for 10 years. And I'll point out some of them that were especially hard for me to stop using because I've used them for so long. It's important to get it to, in this day and age, the term political correctness just causes all sorts of people's, you know, hair to be lit on fire. That's not what we're talking about here. What we're talking about is using language in order to better serve the individuals and the families with whom we work, especially in y'all case, within the Commonwealth, okay? So a guy by the name of Don Coyes, who is a Native American, started the Wellbriety movement, but he made this statement, and I think it sums up the whole concept of what we're talking about. Words are important. If you want to care for something, you call it a flower. If you want to kill it, you call it a weed. Prime example being dandelions, that some homemakers go crazy when dandelions are in their yard, but for other folks, it's they're sort of pretty. Back in 2015, President Obama was in Charleston, West Virginia, and made this observation that we can't fight this epidemic without removing stigma. And he is absolutely correct. And a big reason why the numbers have continued to grow as far as overdose deaths, in addition to the fact of fentanyl appearing on the scene and showing up in a whole lot of other things other than just opioid mixtures, has to do with stigma. Primarily has to do with stigma because, as we'll see in a little bit, stigma and the language we use causes people to not want to get into treatment, let alone acknowledge they've got a problem. Okay, so what in the heck is stigma? All right. The thing about stigma is that there are 2 things that impact stigma, whether something is stigmatized or not stigmatized. And those 2 things are basically cause and controllability. So in other words, if society as a whole thinks that someone is to blame, in other words, they caused whatever the problem is, or that they could control it if they really wanted to, then whatever that is going to be stigmatized, okay? Which is sort of ironic because other chronic medical conditions that fit the same category as addiction, such as type 2 diabetes or hypertension or high cholesterol, are also genetic predisposition and impacted by behaviors, diet and exercise specifically. But we view, and we'll talk about this some more as we're going along, but we view substance use disorders differently, okay? There are three main types of stigma, okay? There's this public stigma, which is what on a day-to-day basis, and it's important to understand that substance use disorders are stigmatized. People that have substance use disorders are discriminated against because of having a substance use disorder. In other words, they're treated differently. The general deal with public stigma is, again, the way the general public views substance use disorders and concurrently the people who have them. It's one of those things that an example I give a lot of times is my grandmother. I'd been in recovery for 17 years. I was helping her to move into an assisted living place that she decided she wanted to move into. She was like 93. And she told my aunt, and I was in the living room and she was in the kitchen with my aunt. She said, "Now, Doris, when we leave to go out to Cartmel, when Ed takes me out to Cartmel, I want you to go in the refrigerator. There is a bottle of Reese's cooking sherry in the refrigerator, and I want you to take it out and dispose of it because he's going to be here in the house by himself, and I don't want him to be tempted." I've been in recovery 17 years, and I looked after my grandmother went back to her bedroom. I looked around the corner at my aunt, and I said, "You do realize that if I'm going to start drinking again, it is definitely not going to be with Reese's cooking sherry that's probably already turned to vinegar. Thank you very much." And of course, my aunt went, "Well, you know how your mama is, honey." That perception that somebody who has a substance use disorder is going to fall over drunk at any minute is part of the stigma, all right? When we're talking about institutional stigma, what we're talking about is the way people with substance use disorders are treated in emergency rooms. And it's one of those deals that we'll talk some more about that in a second. And then that last one is self-stigma. That basically is the where people who have substance use disorders internalize the messages that the general public says about themselves, okay? And the deal is that right there, internalizing that self-stigma is one of the things that prevents people from accessing treatment or for getting help. And we'll look at some other things in a minute. Some additional things, there is also this whole issue within the recovering community of the continuing battle over abstinence versus medication. And one of the things that, you know, and I say this from the standpoint of somebody who has been in recovery for quite some time and has been a member of 12-step communities for quite some time. It's one of those deals that, you know, when people use a phrase like, "Well, that methadone, it's mood altering." Well, yeah, so's that coffee that you're drinking, and so's that donut that you just got through chewing on, and so's that cigarette that you're probably going to have in about 5 minutes after you finish the donut. But we view those differently. And the problem is, right at this particular point in time, that attitude is killing people. That attitude is causing people to leave recovery and go back and start using. And it's like a lot of times people make the statement, "Well, the disease got another one." It's like, no, the disease did not get another one. We got another one because of the stigma that we've placed on people who are stable on medication and doing fine, but we tell them that they're not really sober, okay? Clinicians also are affected by stigma that have been in the clinicians that have been in the field for a while, and they've seen, you know, folks that have had trouble getting into stable long-term recovery. And so they reach a point, it's like, well, treatment just doesn't work. Well, you know, it's sort of like, my feeling about that is it's sort of like saying that a child is too stupid to learn, basically because the teacher won't take the time to figure out how they can present that information to that child so the child will get it. The deal that a lot of times we use as clinicians use the term that, oh, well, somebody's just in denial. Well, that's a convenient cop-out in many cases for sitting down and figuring out what is it that are the barriers to that person getting into recovery. What are the barriers? What are the problems? And a lot of times it's trauma. So we're going to look at real briefly here a little bit of where a lot of stigma comes from. And a big part of that comes from the media. All right. This was from the Los Angeles Times, and it was, you can see it was from 2015. Why cocaine addicts keep making bad decisions. Well, somebody reading that headline, the take home that they're probably going to get is, okay, that addiction, yeah, just like I've always thought, it's a choice, because you make a decision to do bad things. So therefore it's choice, which is not true. But again, those are the subtle messages that keep coming out. This was back in 2007. It was a cover of Time magazine. And, you know, let's just look at it. That fish supposedly represents somebody who has a substance use disorder. Not very friendly, sort of scary looking, plus not real smart, because if you look, that there's not even any bait on that hook, and he's going right for it. And again, that's the message that is conveyed. Another one that was done probably around 2015 that Time did, and I used to show it, or I would have shown it, but it shows a person injecting drugs, and that can be a trigger for some folks. But it's a person, obviously a person of color, and they're in an alleyway. You can see their hand, and you can see that their fingers are dirty, and they just look dirty, and they're injecting drugs. And that was what Time chose to put on the cover of the magazine, representing people with opioid use disorders. Now, if I were a housewife living out in the suburbs, I sure wouldn't be able to relate to that, because that's not me. And that's part of where the stigma causes problems, where people look at what the stigma is represented as, and it's like, no, that's not me. I don't do that stuff. No, I must not have a problem. Some of you might remember Philip Seymour Hoffman. He was an actor who had been in recovery for about 10 years from alcohol and opioids, and he started using opioids again, and he overdosed and died. And what the media said was that he was found half naked in the bathroom with a needle hanging out of his arm. Okay, well, you know, if you stop and think about it, if he had had a heart attack, would they have said that he was found half naked on the bathroom floor with a Big Mac in his hand and French fries scattered across the floor? I don't think so. But it would have been the same thing. Okay. One of the deals that's important to understand, and a lot of people have trouble with this, is that substance use disorders are chronic medical condition. They are. Gil Kerlikowski, who was President Obama's first director of the Office of National Drug Control Policy, and prior to that had been the chief of police in Seattle. He made this statement, which is sort of takes care of it. We know from research that has been conducted by some of the world's leading neuroscientists that drug addiction is not a moral failure on the part of the individual. It's a chronic disease of the brain, and it can be treated. This isn't my opinion. It's not a political statement, and it really isn't open for debate, because the evidence is clear and it's unequivocal. It's a fact born out of decades of research and study, and it's a fact that neither the government nor the public can ignore. And as long as we ignore it, we're going to continue to stigmatize substance use disorders and the people who have them. All right. Now, when we think about medical conditions, okay, just to sort of reinforce this, you know, to where you don't take my word for it. Medical conditions affect specific organs in the body, have identifiable causes, they have identifiable signs and symptoms, and they're either treatable or curable, or they're not. And they can either be acute or chronic. When we're talking about substance use disorders, the organ that is affected is the brain. Okay. And when we were first figuring out back in the late 1800s and early 1900s what was a disease and what wasn't, we didn't know. We didn't know that the brain was the problem. So the people that were making these decisions thought that alcoholism and drug addiction were just bad behaviors. So that's why, if you ever wonder why substance use disorders are a legal issue as opposed to a public health issue, that's it. That's the problem. There are identifiable causes. Part of it is genetic, but there's a whole lot of other stuff that can go into it. You know, trauma, stress, you know, the availability of substances, all sorts of other things that can trigger it. There's specific signs and symptoms. And in the case of substance use disorders, it's treatable. It's not curable, but it's treatable. And it happens to be chronic. Now, this is a definition from the American Society of Addiction Medicine, that it's a primary chronic disease characterized by compulsive substance seeking and use despite harmful consequences. Primarily impacts the limbic system in the brain, but can also affect the prefrontal cortex. It involves cycles of remission and recurrence. 40 to 60% of it is genetic, okay? Now, the deal with this prefrontal cortex thing is that all of the behaviors that people that have a substance use disorder manifest are controlled by the prefrontal cortex. And the prefrontal cortex gets short-circuited by substance use, okay? As far as this responsibility, consciousness, seat of self, where emotional meaning comes in, impulse control, all of those things are done by the prefrontal cortex, which, in case you didn't know, prefrontal cortex usually doesn't finish developing until about 25. And the thing is, those of you that have teenagers, ever wondered when your teenager does something and says, you ask them and they say they don't know why they did it, they're probably telling the truth. Because their prefrontal cortex isn't developed. Now, then we've got the limbic system. The limbic system is part of that basic survival part of the brain. And what happens is that gets hijacked. So basically, after somebody's been using drugs for a certain amount of time, using drugs achieves the same priority as food and air and shelter. So it's like, you know, when we're talking about food, it's one of those survival instincts. It's why people, when they're involved in a plane crash in the Andes Mountains, eat their dead colleagues because of the need for food, okay? Now, when we're talking about acute conditions or chronic conditions, acute, think in terms of flu. Rapid onset, short course may be severe. Gradual, chronic, think in terms of type 2 diabetes or hypertension. Gradual onset, lifetime course, might have acute episodes. The treatment is multimodal. In other words, there's not just one kind of treatment. And the response is variable depending on a lot of different factors as far as the patient, the type of, you know, do they have family support, that kind of stuff. What I want you to do when we talk about some of these words and concepts from here on out, think about it from the perspective of, would you use the same words or would you feel the same way towards somebody who has hypertension, diabetes, or asthma, or other chronic medical conditions? And if the answer isn't yes, then that's yet another example that we're not treating substance use disorders like chronic medical conditions. Something to think about. And this is a good one here. It's like if we treated other diseases the way we treat substance use disorders, what would it look like? And let's look at an example of the emergency room. So if you have somebody who's having a heart attack, okay, and they go to the emergency room, all right, well, if we treated folks with heart attacks the same way as we treat folks with substance use disorders, they would be told, why are you here? It's your fault because of your bad choices. What do you expect us to do? They would probably be denied treatment because you did it to yourself. They'd be given a list of cardiologists and cath labs to call, but not referred to them directly. And they'd only be given an aspirin if they agreed to go to counseling. And if they started having more chest pains, they'd just get kicked out of the hospital. Okay. Those of you that are on this call who have substance use disorders, who have ever been to the emergency room, I have no doubt can attest that this is what you experienced. Okay. And in reality, we would never do something like that to somebody who was having a heart attack or somebody who had type 2 diabetes and their blood sugar was elevated and they were having problems. Okay. If we treated substance use disorders the way we treat other diseases, all that somebody would need to get into treatment was they have to have a substance use disorder. We wouldn't discharge people if they started manifesting symptoms, as in using drugs or alcohol. We would offer treatment on demand. In other words, we would keep people in services for much longer than we do. Triage would be based on the people who are most at need, not the people who don't have a negative wallet biopsy. And again, if there were medications that were part of the treatment, people would be encouraged to go on those medications. You know, there'd be a bunch of different treatment options and the person would have the choice. It wouldn't be a matter of us telling the person what kind of treatment they were going to get. When we're talking about, I don't know if y'all have heard of the phrase person first language, but person first language is basically not defining somebody by their medical condition, okay? Viewing it from the standpoint that that individual is a person first and foremost. And there's a whole lot more to them than just the disease or medical condition that they have, all right? Some examples would be, these terms right here on the left are terms that you would currently hear in a lot of treatment settings and in a lot of 12-step recovery groups. And I gotta tell you, and please hear me, I am not in the least trying to tell 12-step programs what they should and shouldn't do. All right, what I'm talking about, those of us that are in a professional setting, these are the things, we don't need to use those terms. All right, that's the important thing. But alcoholic, addict, drunk, crack or meth head, junkie, needle freak, benzo queen, garbage head, chronic relapser. Chronic relapser is the one that just makes me bonkers. You know, I've got a good friend of mine. She's been in recovery 8 years. She owns her own business, and she continues to identify herself as a trash can junkie, and it causes my blood to run cold every time she does. An alternative term would be, that would be more appropriate, person with a substance use disorder, person in recovery from substance use disorders, person first. All right. These are some examples of that. One of the handouts that are available, has stuff like this also. Bottom line of what we're talking about is that if substance use disorders are a medical condition, then we need to use medical terms, okay? The first one that causes so much problems is this substance abuse or drug abuse. Well, for starters, abuse is not a medical term. Secondarily, the general public puts abuse in the same drug abuse in the same category as domestic abuse or child abuse, which I think y'all would agree is not a real good neighborhood to hang out in. And it's also not accurate because, I mean, you know, substance abuse would be mixing a real good quality bourbon with Hawaiian punch. That would be substance abuse. And I got to tell you, as before I got into recovery, I didn't abuse my substances. I took real good care of my substances. They abused me, but I didn't abuse them. Also, the term misuse, it's not prescription drug abuse, it's misuse. People aren't using the prescriptions the way it was intended. Probably wasn't even their prescription. This whole concept of addiction versus dependence, which we're going to talk about in a little bit, opioids, any opioids and anybody taking them is going to cause dependence. Dependence can be a part of addiction, but it's not addiction. A lot of times, and this is one of the most shaming things that I can think of, when a woman is pregnant and using opioids and she gives birth, Everybody says, oh, that poor baby was born addicted. No, the baby was not born addicted. The baby was born opioid dependent. The baby has neonatal abstinence syndrome. The baby was drug exposed in utero. Okay. Again, sort of like what Joe Friday said on Dragnet, just the facts. Absolutely just the facts. A lot of times we use the term drug of choice, problem being that word choice. We ask that question primarily because we need to know what kind of drugs somebody was primarily using. It's a treatment issue. It's a cultural competency issue. More appropriate way of saying it would be, what was somebody's primary drug of use? Again, just the facts. Another one is this whole concept of denial versus ambivalence. Denial is not a bad thing if you're a trauma survivor. And what we call denial a lot of times is ambivalence, feeling two different ways about the same thing. One hand, you know you need to change. On the other hand, what's familiar is normal, is natural. Why do you think somebody with type 2 diabetes continues to eat that extra slab of cake, knowing full good and well what the consequence is going to be? Another one too is when we use phrases like, oh, they're not ready, they don't want it bad enough, they haven't heard enough, they haven't, they're in denial, they're too resistant. Would you use those terms to describe somebody who had type 2 diabetes? Absolutely not. These are moral and judgmental terms. They are not medical terms, but that's what we use. All right. A lot of times that's what we use. This right here hit me when I saw it. My clients don't hit bottom, they live on the bottom. If we wait for them to hit bottom, they will die. The obstacle to their engagement in treatment is not an absence of pain, it's an absence of hope. That's why the whole concept of peer support is so critical to recovery, because people who are peer support specialists are hope carriers. All right. Relapse goes right in there with backsliding. It is not a medical term. All right. Very stigmatizing. What would be more appropriate would be terms like they had a recurrence or they had a return to use. Get the moral judgmental stuff out of there. Clean and dirty for urine drug screens. Well, they're medical tests. When was the last time you had blood drawn and then you went in to see your doctor to get the results, and the doctor looked at you and said, well, blood work came back dirty for cancer? They wouldn't say that, but we use that term all the time. And the people we work with, people that have substance use disorders, use that all the time. It's either positive or negative, pure and simple. And another one is using the term clean and sober to describe yourself. If somebody is clean when they're in recovery, that means that they were dirty when they were still using drugs. Would you use dirty to describe anybody else who had a chronic medical condition that had not been treated? Nope, absolutely not. All right. One of the big problems with opioids is this whole concept of the negative attitudes that the general public and the people in recovery have about using medication to treat it. You might remember this person. His name is Corey Monteith. He was on Glee. He had been in 3 treatment programs, very high-end abstinence-based treatment programs. And he, again, started back to using opioids after every time. He would have been a prime candidate for medication. Unfortunately, he had been told by those treatment centers that if he took medication, he wasn't really sober. He was still using. So guess what? He overdosed and died, which is the same thing that a whole lot of that 100 and some odd thousand people who died from overdose last year had been told also, which is why they wouldn't go on medication. A whole lot of people who have no medical background are quite free with giving their medical opinions about medication. And we really need to stop that. These are 2 things that are really important. And these are, if you download the handout, you'll see these. Basically what they show is that that if somebody's in a treatment program using medication, they're 59% less likely if they're to experience a fatal overdose. They're taking methadone, and 38% if they're using Suboxone. So it's not that I'm just making this stuff up. This one is even more important. It's done in Maryland, 48,000 people. Again, the deal, 80% of people, if somebody was on a program, they were 80% less likely to experience a fatal overdose. 80%, right? You know, one of the things, I don't know if some of you have ever heard of Maya Angelou. I'm rather fond of her. Especially this one. I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. When we use terms that are stigmatizing, we're not helping people feel any better about themselves. Remember what we talked about, need and hope? Okay, words are the problem. Why, again, what's the relationship? Just to stomp on this a few more times. Stigma causes people to not take advantage of medication used to treat opioid use disorder. It also causes them, if they get into treatment, to have their family members and friends and people they know constantly bug them about hurrying up and getting off medication, which we don't do that with people who have high blood pressure or type 2 diabetes, but we do it with medication for substance use disorders. So I'll leave you with that. We are the problem, but we can fix us. Okay. All right. Thank you so much. And I will end sharing and we can move into some questions here.
Thank you so much, Ed. That was excellent. I'll now like to bring Courtney back on and she'll help moderate these questions. But if you have not already, please use the chat box or the Q&A to submit questions and we'll make sure that they get addressed with our next few minutes on here.
Thank you so much, Ed, for that presentation and for the examples. The examples that you used really help drive the point home. And I've been watching the chat and people are finding those really helpful and want to implement those examples when talking about it in the workplace. So cool. Thank you for that. We do have some questions that have come through. Can you define addiction versus dependency?
Okay. For the thing with addiction, if you want to think in terms of the 4 C's, loss of control. In other words, they can't predict how much somebody is going to use, continuing to use despite negative consequences, experiencing craving. Those are examples. You know, you've got the DSM-5 that gives specifically. Dependence just means that the body or the organism needs whatever that substance is to function normally. All right, opioids cause that. In other words, that's why the flip side of dependence is withdrawal. That's why somebody who's been using opioids is going to, if they stop them cold turkey, they're going to experience withdrawal because they have developed dependence. All right, that's the difference. All right.
Thank you so much, Ed, for that. The next question that came through was, instead of saying clean or sober, what should we say instead?
Thank you very much, because I forgot to tell you all that, or I glossed over it. Oops. I call that age-related attention deficit disorder. That somebody's drug-free, or if you remember what I said, that I was free from alcohol, illicit or non-prescribed medications. Okay, so the easiest one is just drug-free.
Perfect. The next question that came through in the chat is, what is the intersect between the chronic medical condition of addiction and behavior?
The thing is, if you think in terms, a lot of the behaviors that are manifest in people who have substance use disorders originally were coping mechanisms. Because you remember me talking about the fact that And this doesn't happen the first time somebody uses a drug. Now, it's one of those things that with substances like opioids and methamphetamine, it can start fairly quickly as far as this whole concept of dependence, and basically crossing that line into addiction. But once somebody's crossed that line, the issue is using or drinking is no longer an option. It achieves the same status as far as one of those survival needs. If you think of that limbic system, if you think in terms of like a piece of wood and you just run a pencil over it, it'll leave a mark on that wood. All right. If you take a wood burner and run it across that piece of wood, it's definitely going to make a mark on it. And that's what happens with drugs and alcohol on the brain, to where the brain remembers, the brain, it puts it into that same category. So again, the behaviors, a lot of the behaviors are used to survive, to to keep the addiction going. Something too that's really cool, and this was a long time ago, but some of you might remember the Minnesota Multiphasic Personality Inventory, the MMPI. And it was sort of interesting that people who had a substance use disorder who took that test would peg out antisocial personality disorder. They were re-administered the test between 9 months and a year after being in recovery. It would go back down. So again, it's one of those deals that the behaviors are serving a purpose. And part of the challenge of recovery, which is why counseling is so important in addition to medication, is helping people learn different coping mechanisms for life other than by drinking or using. Okie doke.
Thank you, Ed. The questions keep rolling in. Maybe we have time for 2 more. Can you talk about harm reduction as a pathway to recovery?
Thank you so much. I got my start in the field doing HIV work. So the concept of harm reduction was not foreign to me. It causes a lot of addiction professionals to just, bounce off the walls. The bottom line is harm reduction is meeting somebody where they are at. Okay. If you think in terms of us wearing seat belts, that's harm reduction. Sunscreen is harm reduction. It's like a doctor, when the doctor meets somebody who has type 2 diabetes, who, say, for example, has not been eating well, and so their A1C levels are going through the roof, the doctor is not going to beat up on them about changing the behaviors. The doctor's going to find out what happened, and if need be, the doctor is going to adjust their meds, because the bottom line is the doctor wants to keep that person alive. All right. I like to tell people, it's like, okay, if your concept is that abstinence only is the only way to go, that's fine, but it's awful hard to do that with somebody who's dead. And one of the deals too is that there is, when you meet somebody where they are at, and somebody might not be at a place where they want to stop using, you meet them where they're at, they learn to trust you, and they may or may not move into, going into some kind of treatment. But the bottom line is you're keeping them safe, and you're not causing the societal harm that actively using a lot of substances causes. But most importantly, it's about that other person, meeting them where they're at, as opposed to pushing or telling them where they need to go. It's pragmatic. It's just pragmatic from the standpoint of it's about, not about, it's like teaching abstinence only education to kids. It's one of those deals, same thing. It's like, yeah, it might work for some of the people, but not for everybody. And that's a big part of the problem. You need to tailor it. And I think we need to focus more on harm reduction. All right.
Thank you, Ed. I'm going to ask you one more question, then we'll hand it over to Michelle for the wrap up. What strategies do you recommend to educate people who hold tight to these stigmatizing views?
The issue is for that. Let me give you an example. When I went through treatment 38 years ago, the concept behind treatment was you have to tear somebody down in order to build them back up. And that did a whole lot of damage. Even though we thought it was. A lot of people, and I'll be honest with you, there are some folks in recovery who you are never going to get it. They will not get it. You know, it's one of those things. Don't drink, read the big book, call your sponsor, go to meetings is as good as it will ever get for them. My point as far as helping get these points across is if it makes a difference and one more person stays in recovery because I don't call them an addict, I think it's worth it. It's like, that's the key. If one person stays on medication, their life is better. And, you know, a prime example, real quick example. One of my patients, when I worked at an opioid treatment program, been on methadone for like 25 years, 24 and a half, was one of the had no positive drug screens. She went back to college, got her teaching certificate, and she made the decision to start tapering. Well, she also got into Narcotics Anonymous, and the woman she asked to be her sponsor said yes, but we're not going to tell anybody else that you're on methadone. And so she continued her taper, and the beauty of it was when she got down to finish it out, she had a support network that helped her not return to use. So the issue is helping people get it, that it's like somebody else's recovery is none of my damn business. If it works for them, that's all that matters. And the thing is that some folks, you know, are just not going to get it. And I'll be honest with you, I've done this more than once, as far as when somebody makes their uneducated opinion on somebody taking medication to some newcomer, I quickly stick my nose in the conversation and point out the fact they aren't a doctor. So they need to keep their opinion to themselves. We don't share opinions, we share experience, strength, and hope, period. And your opinion really doesn't matter. So there you go. Ed will get off his soapbox now and turn it back over to Michelle.
Thank you so much, Ed. Michelle, would you give us a wrap up, please? You're still on mute.
Thank you so much. I know we're coming close to time, but I wanted to address some of those last few questions. For those interested in a certificate of attendance, I'm asking that you please email me. I am putting it into the chat box. We are still in the process of developing the certificate of attendance process, but we would want to provide the support if possible. We'll also collect the remaining questions that weren't answered and try to put together something like a frequently asked questions. Also, there was a number of resources mentioned throughout the event. I'd first like to call out the Addiction Language Guide. This is a shatterproof research with comprehensive information about stigmatizing language and how we can use person-first terminology. And it has gone through incredible vetting. Several research studies and academic studies have been cited if you were looking for additional information. To download the form, you can find it on the UNSHAME Kentucky website under the Resources tab. Ed has also shared with us the language of recovery guides, as well as the most respectful way of referring to people is as people document. This will also be available on the UNSHAME Kentucky website. Finally, I'd like to do another thank you and promote the Office of Vocational Rehabilitation. You can visit their website for more information on your local office, how to apply for services, and determine your eligibility. Thank you so much for joining us. Next month, our webinar will be on redefining recovery. We'll be featuring some professionals across the Kentucky area to talk about their own experiences. And we'd love to have you guys participate. You will also receive a flyer about this in your emails for registering for this event. And with that, there are a few more links for you to get involved. Follow us on our social media. If you're interested in becoming a partner of the campaign, you could also contact our program coordinator, Marissa Williams, at mwilliams@shatterproof.org. Thank you so much for your participation today, and follow along to what we hope to produce when it comes to different resources, webinars, capacity building opportunities throughout this campaign. Thank you.